Hello everyone, welcome to my YouTube channel. So today's topic is we will talk about antepartum hemorrhage. In that the main concerns will be placenta previa and abruptio placenta. So we'll start. We'll start with first is what is antepartum hemorrhage. So what is antepartum hemorrhage? What is antepartum hemorrhage? It is the bleeding from vagina, okay, vaginal bleeding or bleeding from the genital tract after the period of viability. So what is the period of viability in India? In India the period of viability is beyond 28 weeks. So any bleeding occurring from the vagina beyond the period of viability, that is 28 weeks, that is called as antepartum hemorrhage. So which is more common among abruptio and previa? Which one is more common? So abruptio rate is 0.5% and previa rate is 0.3%. So more is abruptio placenta. So we'll start with the placenta previa. So placenta previa is what? Placenta previa is nothing but when the placenta comes ahead of the baby, that is called as previa. Previa means first. So you can see in this picture there are 4 types of placenta previa. So this first one is the normal position of the placenta, where the placenta is situated on the upper segment of the uterus. So next picture, the type 1 is what? This is the internal os, okay. So from the internal os to the outer membrane, the diameter should be 2 centimeter, that is type 1, when the placenta covers within 2 centimeter of the internal os, okay, that is called as the lower uterine segment within 2 centimeters of the internal os, that is the type 1 placenta previa. In type 2 what happens? Type 2 placenta previa where marginal, okay, this is the internal os here, okay, this margin is getting covered in marginal type, that is type 2. Then comes the type 3, also called as partial. So the internal os is partially covered with the placenta. So this comes as a type 3 placenta previa. And type 4 is complete. So completely the os is covered with placenta. So these are the 4 types. So among these, type 3 and 4 are considered as major degree placenta previa, and type 1 and type 2 considered as minor degree placenta previa, okay. So there are some terms like type 1 and type 2 are given a term as low lying placenta, and type 3 and type 4 are given a term as placenta previa. So when someone is saying placenta previa, so you have to consider it as type 3 or type 4, and when someone is saying type 1 or low lying, that means it is type 1 and type 2 only. Then we will come to the risk factors. So what are the risk factors? So increase in the maternal age. Increase in the maternal age is the first risk factor. Second is increased parity, maternal smoking, prior history of placenta previa. So if the mother is having any prior history of placenta previa, there is recurrence of 5% in that mother, that she will have the next pregnancy also of placenta previa. Then in case of multiple pregnancies, so it is common that in multiple pregnancies there may be either 2 placentas, so there is a less space in the uterus, so it may cover the internal os or it may cause placenta previa. Then history of previous C-section, okay, in previous C-section there is 5 times increased risk of placenta previa, because in C-section the mother is getting a scar on the abdomen, okay. So inside also in the uterus there is a scar, so there is a high risk of the placenta to get adhere to the scar site. So history of previous C-section is also very common. Then uterine anomalies. Next we will see the clinical presentation of placenta previa. So this is the normal placenta, okay, where it is attached to the upper segment of the uterus, and this is the placenta previa, which is completely covering the internal os of the cervix. Okay, so what is happening is, in case of placenta previa, there will be bleeding per vaginum. Okay, bleeding per vaginal, and first bleed will always be a warning sign, a warning hemorrhage, and it means that you need to keep the mother under observation. So it doesn't mean that one time bleeding is occurred, that means next time it won't happen. You don't even know that next time when it will happen and how much time it will happen, how much amount it will happen. So always a warning hemorrhage must be kept under observation. And in labor there will be cervical dilatation. If mother is in labor, cervical dilatation will occur, and in that case more bleeding will be there. So that is why whenever a patient comes with placenta previa, you always have to note the patient's vitals including what? BP and pulse rate. Okay, so a mother can be in shock. That is why taking vitals is very important. Next is, you have to see the character of the bleeding. Character of bleeding, what will be the character of bleeding is, there will always be a fresh bright blood. Why? Because the placenta is getting covering the internal os. Okay, so there is a fresh bleeding with a red vaginal bleeding. Okay, fresh bright red vaginal bleeding will be there, and it will always be without pain and without any cause. So without any trauma, any reason, mother will tell that suddenly she was found in the pool of blood, and she won't even come to know because there is no pain. So that is the main characteristics of the placenta previa. Next we will see on abdominal examination what will happen. So the uterus will usually be relaxed in abdominal examination. The fundal height, normally the fundal height is equal to the period of gestation. Okay, usually. But in placenta previa, usually associated with malpresentation. What happens? That because of the placenta is covering the internal os, and it is not giving space to the baby's head. Okay, so in that case what will happen? The baby will take a different position, and usually cases of placenta previa will show with malpresentation. Next is fetal heart rate. The fetal heart rate will always be normal. It is not compromising with the fetal condition. On vaginal examination, okay, so always remember, in placenta previa, the placenta is covering the internal os. So in this case, vaginal examination is absolutely contraindicated because it can trigger bleeding. Okay, so always, if you are in doubt that the mother is having placenta previa clinically, you don't have to do vaginal examination. That is why the investigation of choice is USG, transvaginal sonography, is very much safe. It is a better option than for vaginal examination. So in this picture you can see diagnosis of placenta previa in USG, that this is the bladder of the mother, this is the cervix. Okay, the cervix is getting covered with the placenta. Okay, this is the placenta and this is the baby's parts. So placenta is coming in between, so it is a very clear visualization of the diagnosis of placenta previa. Now what are the management concerns of placenta previa? So we have two concerns, mainly mother and baby. So in case of baby, if the baby is preterm, that is less than 34 weeks of gestation, that means the baby's lungs are not mature. Okay, so we cannot deliver now, so we have to wait for the baby's lung maturity, and also we have to think about the mother. Then we will go for the conservative management. The conservative management, there is one famous protocol called as McCafe protocol. So it is done for the baby's sake, because the baby's lungs are not mature. Okay, lungs are not mature. So in this case what we have to see is whether the mother is stable or not hemodynamically, and then always you have to do this from term. If the baby is less than 37 weeks, then only you have to wait. If baby is more than 37 weeks, no need to wait because lungs are already mature. and we have to see whether there is no active bleed, then only we can wait. And if there is active bleeding, that means mother will go in shock, and then you have to directly go for the surgical management. And also you have to see that the baby is healthy. In surgical management, always one option is there, that is C-section. Okay, C-section when we will do is when continuous bleeding is there, and I told you that if mother is unstable, that means hemodynamically, no matter what is the period of gestation, you have to do C-section. If more than 37 weeks, if the mother goes in labor, if baby is in distress, then you need to do C-section. And if the baby is dead, so if the baby is dead, we are not doing this procedure to save the baby, we are doing this procedure to save the mother. Then next, so now we have completed the topic, that placenta previa. I hope you understood. Now we will continue with the abruptio placenta, it is placental abruption. So what is it? It is nothing but a premature separation of the normally situated placenta. Okay, so in this picture you can see that this is the placenta. This placenta is getting separated from here, from here, from here, from here. So these are the 4 types of separation: retroplacental, marginal subchorionic, preplacental, and intraplacental. So what we are seeing is when the placenta gets abrupted from the uterus, okay, there are some arteries in the uterus which get ruptured. So as soon as it gets ruptured, there will be active bleeding in that site. So in case of retroplacental bleeding, the bleeding will be collected behind the placenta and it will lead to a severe condition. Okay, so this is called as concealed type of bleeding because the blood is getting collected. So what is the pathology? Hemorrhage in the decidua basalis. Okay. 2 types of abruption will be there, that is, one is concealed one, second is revealed one. So I told you already, retroplacental hematoma will be there, blood is collected behind the placenta. So in this case you have to note the vitals. Why vitals? Because bleeding is getting collected, so clinically mother may not show, but when you take the vitals, her BP will be low, she must be in hypotension, she must be in shock. So that is why it is the most dangerous, because patient won't show any clinical signs. Then next is the revealed type. Revealed type में there will be visible bleeding and marginal abruption of the placenta. After hemorrhage, the what happens in concealed type is, after hemorrhage, the placenta thromboplastin is released. Okay, placental thromboplastin will be released and it goes back into the mother's circulation. So for example, here bleeding is happening. Okay, bleeding happened, so here placental thromboplastin is there. Now it will go where? It will go back into the mother's circulation, and when it goes back into the mother's circulation, what will happen? It leads to DIC, okay, disseminated intravascular coagulopathy, and it is more common in the concealed type. That is why concealed type is the most dangerous one. What are the risk factors of abruptio placenta? Is increase of maternal age, same like placenta previa, increased parity, maternal smoking, prior history of abruption. Any mother will complain of abdominal trauma, that she has fallen down suddenly or she met with an accident. So abdominal trauma will be there in abruptio placenta, but in placenta previa there will be no cause. And preeclampsia condition, then antiphosphorylated syndrome, then polyhydramnios. Okay, polyhydramnios, why? This is the uterus for example, and sudden leakage is there. Because of polyhydramnios, the pressure increase and sudden leak of the amniotic fluid will be there. So that time what will happen? Suddenly pressure will come on the placenta and placenta may also get abrupted. What are the clinical presentations? So same in this mother also, you have to note the vitals because active bleeding is there. Note the degree of separation. So the degree of separation will be given by a one classification, that is called as the Page classification. It will give you an idea of the severity. What is the character of the blood? Always in abruptio placenta you will see altered dark blood, and in placenta previa you will see red bright blood. Associated pain will be pain or labor pain also. Okay, and on examination you will feel that the uterus is tense and tender. Also uterine tone will be increased. So uterine tone increase means that uterus is not relaxing completely. Also the fundal height will be more. Why? Because there is collection of blood in the uterus. Okay, blood is getting collected in the uterus, so there will be increase in the uterine height in concealed type. And then what will happen to the fetal heart rate? Because the placenta is getting separated, so there is no oxygen supply to the fetus. That is why the fetus will go in distress. A vaginal examination will always, you have to always rule out placenta previa first on USG. Then only we can do vaginal examination. Otherwise you can't do. Because if it is a case of previa, then you are harming the patient. What is the diagnosis of the abruption is mainly clinical. So USG is not required. Only on vaginal examination you can find out it is abruptio placenta. How we will do the management of the abruptio placenta is definitive management is always termination of pregnancy is the definitive management by augmentation of labor. Okay, then what is the prime concern? Prime concern is resuscitation of the mother hemodynamically, because she is bleeding actively. So side by side, when you are terminating the pregnancy, you have to stabilize the mother hemodynamically, and preferred route of delivery is always vaginal. Okay, because preferred route of delivery is always vaginal. If the fetus is in distress, then only we go for immediate cesarean section. Okay, so this was all about abruptio placenta and placenta previa. Thank you for watching my class, and please subscribe my channel and share to your friends. Thank you.